Hello everyone, happy afternoon, a very good afternoon. Am I audible and visible, everyone? Let me see if I can see the live chat. Just give me. All right. Happy afternoon, everyone. I hope and I believe all of you are doing well. And I can also understand that looking at the poll results also that majority of you are anxious, you are stressed about your upcoming FMG exam. And right, I think almost all of you are feeling that stress and anxiety. But honestly, trust me that the more relaxed you are, the better you would perform in your exam. All you need to do in your the remaining days that you have, the remaining 4 days, 5 days that you have before your exam is just try to stay calm, close your eyes and visualize, how would you want your exam hall, the process to be, how you want to be happy looking at each question. Oh, I know this, right? So just visualize that rather than getting stressed about it. Visualize yourself coming out of the exam hall with a big smile and a satisfaction that, I have given my best and I believe that I will get the best results as well. Okay, so please do not let the stress and anxiety overpower you and decrease your productivity, right? And that's why we are going to meet up, right, almost every day till your exam starting today. So we have the Sureshot final punch for the FMG exam. This is the first session that we have. We are going to have it daily, like on 8, 9, 10 January as well. And then on 11th of January, I'll be discussing about the exam hall strategy, right? The final calm down session, the countdown and the calm down session that we are going to have. Okay. I'll try my best to take a bite. This proves that I'm a good doctor, that my handwriting is bad, but I'll try to write it better. And sure, right, anybody who's struggling with pharmacology, guys, I would still suggest please watch the Sureshot Pharmacology. It covers your majority of the stuff with all the tricks and easy mnemonics. If you can do that, there's nothing like that. Okay, right? So this session will cover the topics which is focused on medicine, right? Integrated like systems wale topics hai, and definitely you would get questions out of this in your exam, right? And like these are the topics which are like must know and frequently asked. In the remaining sessions, we'll try to cover the remaining subjects as well and the most frequently asked topics that you cannot afford to make a mistake in, right? But of course, a disclaimer here that this does not cover, of course, all the topics that are going to be asked in your exam, but definitely you would see questions from the topics that we are discussing in your upcoming exam, right? Please complement this with the short videos available on the Radsynapse app so that, you are able to remember a lot of stuff. Okay, it's going to be mixed bag, Dr. Devnathan. We are not doing subject wise, mixed bag topics that we are going to do. That's great. Okay, so without any further delay, let's start. And like I said, this is part 1. We will have 2, 3 and 4 also. This is today is 7th of January. Then you will have 8th and 9th and 10th of January. You are going to have the sessions. Like tomorrow, again, we are going to meet up. It's going to be a YouTube live session itself at 12 noon. So tomorrow we will meet again for the rest of the important topics to be discussed. Okay, I'll share the PDF. I'm really sorry I forgot to share the PDF before the session. I'll share the PDF post session in the Telegram group. So please stay connected on Telegram group where I'll give you update about other sessions as well. Okay. All right, Selvam, in the last days, should you focus on revision or MCQs? Revision, I think, because you must have done enough of the MCQ practice now, right? So focus on revising the theory part so that you can cover majority of the stuff. So focus on that. Okay. Yeah, let's start with this. And the first one that we are going to discuss, very important topic, never make mistake in this, acid-base disorders. The first question that you have here, tell me what acid-base disorder is this one? Shivani, consider like approximately 1.5 hour. Yes. Towards the end of this session, I'll also talk about Sagar, what you should be doing in these last days. Okay, so stay connected till the last so that, last mein wo bhi discuss kar lenge. Tell me, what acid-base disorder is this that you are seeing here? Very good. Respiratory acidosis. Why respiratory acidosis? So for acid-base disorders, just remember the mnemonic, which is ROME. What is ROME? ROME stands for respiratory में opposite changes, metabolic में equal changes or same changes, same, ME, metabolic. Right? In respiratory, it's opposite. In metabolic, it's equal. So what you need to understand here is the opposite change that we are talking about is the changes in pH and the changes in bicarbonate or PCO2. Okay, the changes go opposite. If the pH is decreasing and both of these are increasing, that means this is respiratory disorder. Because the pH is decreasing, it is acidosis. Okay, so to decide that whether it is acidosis or alkalosis, you need to know what are the normal values for pH, right? So remember, your normal values that you have, they are 4 containing values. So like you have normal pH is 7.4. Okay, normal bicarbonate is 24, normal PCO2 is 40. Okay, bicarbonate starts with bi, so it starts with the bi number, that is 2, and the next number will be 4. CO2 ending in O, that is 0, it ends in 0 and starts with 4. Right, because many times in the exam you do tend to get confused between these small things, right? So have the tricks so that even if you are stressed and panicking in exam hall, these tricks will help you for effortless recall. Okay, so pH is 7.1, that means pH is decreased, so that means this is going to be acidosis. This is the first step that you do in identifying acid-base disorder. Next one that you have here is PCO2 is 50 and bicarbonate is 28. So PCO2 is increased more than 40. This is increased more than 24. That means they are going opposite to pH. So that means it is going to be ROME ke hisab se what acidosis? This is going to be respiratory acidosis. Okay, this is going to be respiratory acidosis. Clear with everyone? Going to the next one. Tell me what acid-base disorder is this? Again, the pH is less. The PCO2 is also less, the bicarbonate is also less, so it is all decreased. Everything is going in the same direction. So this is metabolic disorder. This is going to be metabolic acidosis. Okay, this is going to be metabolic acidosis. Is this clear with everyone? Right? Is this clear with everyone? So metabolic acidosis, important things that you need to remember is HAGMA and NAGMA. That means you have high anion gap and normal anion gap metabolic acidosis. Where does anion gap increase? In high anion gap metabolic acidosis. So if I ask you the question, what are the causes of NAGMA, normal anion gap metabolic acidosis? Easy trick to remember that is, remember NAGMA is Didi. NAGMA कौन है? हमारी दीदी है. So remember NAGMA दीदी. दीदी stands for DI for diarrhea, DI for diarrhea. Right, so NAGMA is seen with diarrhea, normal anion gap. What diarrhea? GIT diarrhea and renal diarrhea. What is the renal diarrhea called as? Renal diarrhea is called as renal tubular acidosis. Very important. You are never supposed to forget this. Diarrhea and renal tubular acidosis are NAGMA ke causes. And even in RTA, your favorite question for the exam, which RTA has hyperkalemia? More potassium, more is seen in 4. Okay, so RTA type 4. RTA type 4 is where you have basically hyperkalemia. Otherwise, RTA type 1, RTA type 2, they are going to be hypokalemia. Right? Please watch that video of renal tubular acidosis. We have it in the app already. Surplus topics. Okay? Right. See, Mohammed Anash, when you are talking about the mnemonic ROME, the opposite wale changes, same wale changes, basically we are talking about compensation में ये जो changes हो रहा है उसके लिए. Okay, so in respiratory acidosis, pH decreases, PCO2 increases, that's a primary change, and the increase in bicarbonate, that's a compensatory change, right? So that's a compensation one. Okay. Acid-base disorders again has been discussed in more details in the short videos, right? This is just a glimpse of it. That is like a must know for everybody. Okay. Remember, diarrhea causes acidosis and vomiting causes. What does vomiting cause? In vomiting, the acid goes out. Vomiting causes alkalosis. What kind of alkalosis? Metabolic alkalosis. It's a metabolic disorder. It's not a respiratory disorder. Okay. So, vomiting causes metabolic alkalosis. Tell me, what do you see at high altitude? What do you see at high altitude? High altitude. Yes. So at high altitude, you know that at high altitude what happens is oxygen is less. So the person is hyperventilating. When it is hyperventilating, so respiratory wala problem, okay, यहाँ पे क्या हो रहा है? Respiratory alkalosis. The CO2 washout, respiratory alkalosis is what you see at high altitude. So mountain sickness के लिए what is the drug that we give? Very very important question and frequently asked. क्या देते हैं mountain sickness में? We give acetazolamide. Okay, the drug of choice here is acetazolamide, which is given for mountain sickness. Okay, mountain sickness. Absolutely right. Going to next one, important points in hematology. All these are based on the PYQs that have been asked in your exam, right? And the ones which have been asked very frequently and repeatedly asked. So that is what we are focusing on here, right? So please revise this entire thing that we are discussing very, very well. Elective splenectomy is done for which condition do we do elective splenectomy? Elective splenectomy is done for hereditary spherocytosis. Okay, hereditary spherocytosis, we do elective splenectomy. Hereditary spherocytosis, we do elective splenectomy. On the other hand, if the question is in which condition do you see autosplenectomy? Autosplenectomy is seen in which condition? Autosplenectomy is seen in sickle cell anemia. Okay, sickle cell shows autosplenectomy because of the splenic infarcts, while in hereditary spherocytosis we do elective splenectomy. Okay, we do elective splenectomy. Very, very important point for hereditary spherocytosis. Okay, I'll write the extra points on the next page, right? So as to prevent that khichdi formation. Hereditary spherocytosis, what happens to osmotic fragility? What is happening to osmotic fragility here? Remember, in hereditary spherocytosis, the osmotic fragility, the RBCs, because of the spherical shape, they are more fragile, right? So the osmotic fragility is increasing. Okay, the osmotic fragility is increasing. There is defect in spectrin, encheirin. Defect is what you see here. Spectrin, encheirin defect is what you see here. Okay, clear with everyone? Going to next one, hemolysis precipitated by oxidative stress. Very, very important. Anti-malarial drugs. Patient is on anti-malarial drugs like primaquine and there is hemolysis precipitated. Oxidative stress में जब hemolysis हो रहा है, basically what is defective here? It is G6PD deficiency. Okay, G6PD deficiency. G6PD is the rate limiting enzyme of which cycle? G6PD is the rate limiting enzyme of which cycle? Remember, hum 5 gunde 6. G6 is gunde 6. Hum 5 is HMP pathway. It is the rate limiting enzyme of HMP pathway, right? And what is the main product of HMP pathway? It is NADPH. Please remember this point. It's NADPH and not NADH. It's NADPH which is formed here in HMP. There's no ATP which is formed. Okay, this NADPH is very important to maintain glutathione, which is the free radical scavenger in the reduced state. And that is why oxidative stress handle hum nahi kar sakte when there is G6PD deficiency, right? For students who have attended the Sureshot or the Sureshot exercise with me in the Radsynapse app, tell me that which other enzyme deficiency can have features similar to G6PD deficiency. It can have hemolytic anemia. right? Which other enzyme deficiency? It is like your extra edge question. G6PD deficiency, which other enzyme deficiency? Okay, I'll give you two options. Okay, you have to choose out of that. Is it pyruvate kinase or is it pyruvate dehydrogenase? Let me write down here. Okay, similar to G6PD deficiency, is it pyruvate kinase deficiency or pyruvate dehydrogenase deficiency? Very good, Sheravali, absolutely right. It is pyruvate kinase deficiency. Okay, because both of them will basically present with hemolytic anemia, because in both of them, if you see, G6PD is HMP pathway, pyruvate kinase is your enzyme of glycolysis. These are the two pathways which are very very important for RBCs, glycolysis, HMP, right? तो किसमें भी इसमें defect हुआ, and in that case what will happen, the RBCs will not be able to bear the stress and there's going to be hemolytic anemia. Absolutely right. Versus in pyruvate dehydrogenase deficiency, there's going to be lactic acidosis. Okay, there's going to be lactic acidosis, which is going to be mentioned in pyruvate dehydrogenase. FMG students, please note this is one of the recent NEET PG exam question, and that is why high probability of being repeated in your exam as well. Okay, pyruvate dehydrogenase will have lactic acidosis as a feature. In G6PD deficiency, we see Heinz bodies and bite cells. Okay, Heinz bodies are seen, which is basically because of denatured hemoglobin, and that is removed by the spleen, and that gives the bite cells. Okay, Heinz bodies and bite cells are seen in G6PD deficiency. And never forget that this G6PD deficiency, what inheritance is it? It is X-linked recessive, right? The story of X-linked recessive. Remember the 6 goons in our story that we have learned? Sureshot में 6 goons वाली जो story थी, X-linked recessive है ये. Bruton, Leshnihan, Granny wali story, 6 goons, Dishum, color blindness, right? Please never forget this, that G6PD deficiency is X-linked recessive. Correct. When you have this classical history of dark brown urine in the morning, dark brown urine morning में हो रहा है, मतलब रात में there is this hemolysis which has occurred. So remember, it is paroxysmal nocturnal hemoglobinuria. Why is it occurring at night? The hemoglobinuria, the hemolysis which is occurring, right? Why is this PNH occurring at night only? Because remember, at night what is happening is there is increased complement activity at night. Increased complement की वजह से ये होता है, right? Because what is deficient here? There is deficiency of CD55 and CD59, which is basically the inhibitor for the complement system, right? And that is why the complement gets overactive. Okay, decay accelerating factor, and you have PIGA gene which is defective here. Okay, remember PIGA gene which is defective here. This is paroxysmal nocturnal hemoglobinuria, right? Acidic pH, correct. And remember, the monoclonal antibody which is used in the treatment of PNH is? What monoclonal antibody is used in treatment of PNH? Emicizumab or eculizumab? Emicizumab or eculizumab? What is used? Yes? Correct. Remember, it is eculizumab and not emicizumab. Okay? How do you remember this is? Remember, MEC and EQ. EQ is, E is 5th alphabet, A, B, C, D, E 5th alphabet, and C. So this is inhibiting C5. This is a complement inhibitor, eculizumab. And where do you use emicizumab? Where do you use emicizumab? Very good, Sheravali. Correct. It is 8 mimicking factor. Remember, emicizumab is a 8 mimicking factor. It is factor 8 mimicking. So you use it in factor 8 deficiency, that is hemophilia A. Okay, you use it in hemophilia A, emicizumab. Okay, so this is important. You should definitely know this. Going to next one, TRAP positive. What is TRAP? Tartarate resistant acid phosphatase, not alkaline phosphatase. TRAP positive middle-aged patient with splenomegaly, pancytopenia, right? There's no lymphadenopathy, but there is splenomegaly, pancytopenia. This is going to be hairy cell leukemia. Okay, this is going to be hairy cell. So remember that in hairy cell leukemia, it is TRAP positive. And what is the drug of choice here? A person who's clad with hair. Okay, a lot of hair, clad with hair. Drug of choice is cladribine. Remember, drug of choice is cladribine here. And what is the specific CD marker for hairy cell? Remember hairy cell, imagine this is the face, yahan pe there is hair and this is the ears. So it is 103. Okay, remember it is CD103, which is the marker, the CD marker, specific marker for hairy cell leukemia, CD103, right? Correct, very good. It affects the red pulp, not the white pulp. Remember what color hair is this? This is red color. Okay, so remember it affects the red pulp and not the white pulp of the spleen. Okay, it affects the red pulp. Correct. Coming to vitamin B12 deficiency and folic acid deficiency, what is the similar finding in between the two? Similar finding in between the two, very good. Both of these will have megaloblastic anemia. Okay, both of these cause megaloblastic anemia with increased MCV. Right, large RBCs are there, but the difference is with vitamin B12 deficiency, there's going to be neurological features also present. What columns does it affect? What tracts does it affect in the spinal cord? It affects the dorsal column. Never ever forget this. It affects the dorsal column, which carries the vibration proprioception, right, causing SACD, subacute combined degeneration of the cord. Okay, no neurological findings in folic acid deficiency. The vitamin B12 deficiency is seen in vegetarian patient and folic acid deficiency is seen in a person eating junk food. Okay, not eating the foliate vegetables, that is leafy vegetables nahi kha rahe hain, sirf junk food kha rahe hain, to hota hai. Other important lab finding that you have is vitamin B12 is methylcobalamin. So remember, it is methyl malonic acid is increased. Here there is increased methyl malonic acid. Here there is normal methyl malonic acid. Okay. Where will you find increased homocysteine levels? In both of these. Okay. Both of these have megaloblastic anemia with increased homocysteine. Right. Remember, homocysteine mein multiples of 3 wali deficiency hoti hai. 6, 9, 12 except 3. Vitamin B6 deficiency, B9 deficiency, B12 deficiency, right? So remember, methyl malonic acid increases in vitamin B12 deficiency. Very, very important. Okay. Going to next one, Casals necklace is seen with pellagra, right? The dermatitis part, Casals necklace is dermatitis, which is 4 Ds. You have diarrhea, dermatitis, dementia, and death. And Casals necklace, pellagra, vitamin B3 deficiency. Classical history given with B3 deficiency is patient eats what? What is the staple food here? Remember 3 ko jab main turn karu, it becomes M, right? A person eating maize. Maize wale food se hota hai pellagra, that is vitamin B3 deficiency. Correct. Basophils, right? Basophils are increased in which leukemia? Basophils, AML, CML, CLL, ALL. It's going to be CML. Okay, myeloid wala hota hai basophil, so it is CML. What is the drug of choice for CML? Very important question. Remember, it is imatinib. Okay, it is imatinib, which is the drug of choice. In CML, you also see this Philadelphia chromosome, which is what translocation? Translocation 922. Philadelphia chromosome, translocation 922. Next one, crab features. What are the crab features in elderly seen in? Multiple myeloma. What is a crab? C for calcium increased, R for renal failure, A for anemia, and B for bone pain. Okay, so there's going to be hypercalcemia in multiple myeloma. Okay, multiple myeloma is a tumor of what cells? It's a tumor of plasma cells. Okay, so basically there is plasma cell infiltration in the bone, right? And that leads to anemia, that leads to bone pain. There's hypercalcemia. Please remember here, alkaline phosphatase is normal. Okay, alkaline phosphatase is normal. There is no new bone formation in multiple myeloma. It is just the lytic lesions that you are seeing there. There's no new bone which is formed, and that is why alkaline phosphatase is normal, and therefore it also shows the cold spot on bone scan. Okay, another important point, it shows the cold spot on bone scan. You see punched out lytic lesions in the skull. Okay, what is the drug of choice here? What drug do we give here? Remember, in treatment we give bortezomib. Correct. Bortezomib is given here. The question is, what is the mechanism of action of bortezomib? Remember, this bortezome is your proteasome. It is proteasome inhibitor. Bortezomib is proteasome inhibitor. Okay, that is used here in the treatment of multiple myeloma. Okay, clear with everyone? Very good, Dhwani. Absolutely right. Exactly opposite condition of, where you have only alkaline phosphatase is high is going to be, where do you have very high alkaline phosphatase? Calcium and phosphorus is normal. What is that condition? Opposite to multiple myeloma. Multiple myeloma has high calcium, ALP normal. Here you have ALP very high, calcium is normal. That is going to be Paget's. पेजेट्स में alkaline phosphatase बहुत बढ़ जाता है, ठीक है? That's going to be Paget's. Correct. So that was about some important points in hematology. Going on to cardiology, very, very important topic, constrictive pericarditis. Pericarditis, which is constricting the heart, right? So what are the features that you see here? What are the features that you see here? Remember, constrictive pericarditis, you can write as constrictive, K. So remember the two K's and K's here. What are the two K's here? One K is the Kussmaul sign and the other one is the knock, the pericardial knock. Kussmaul's and knock is seen here. Okay, what is Kussmaul's? Kussmaul's is basically increase in JVP on inspiration. Inspiration may, with the negative pressure, the JVP should come down, but here it is increasing. Okay, and what is pericardial knock? It is mentioned in the question like a early S3 sound. It comes in the diastole. It looks like a early S3 sound. That is what is given. The patient has history of shortness of breath, which is given here, right? And remember, in constrictive pericarditis in JVP, what do you see in JVP? Very, very important. Constrictive pericarditis, cardiac tamponade, JVP, favorite question for exam. Remember, constrictive pericarditis is CP. CP stands for combined present. That means X decent is also present, Y decent is also present. None of them is absent. So remember, CP is CP combined present. X present, Y present. Okay. There's rather a steep Y descent which is present here. A steep Y descent. Very, very important. Low voltage QRS and ECG, that's going to be your fluid wala, tamponade. Okay. Okay. Yes. So that's how you remember. This is CP, that is combined present is what you have in constrictive pericarditis. What do you see radiologically in constrictive pericarditis? It is called as calcific constrictive pericarditis. So there's calcification present. Common cause in our country is TB. Okay. Okay? Yes, Pooja. They both are different. Kussmaul's is increase in JVP on inspiration. Pulsus paradoxus is related to your blood pressure. Okay, right. Going to next one, drugs decreasing mortality in heart failure. Does digoxin decrease the mortality in heart failure? No, right? Very, very important. Remember, it is not digoxin, a frequently asked question. Digoxin does not affect mortality or survival. Okay, what is the mechanism of action of digoxin? It increases the calcium in the heart by inhibiting sodium potassium ATPase, and that is how it increases the contractility of the heart. Okay, it is not affecting the survival. If you want to decrease the mortality, basically you will have to inhibit the remodeling which is occurring in the heart. The remodeling in the heart which occurs is via two mechanisms, that is sympathetic system and the RAS system. So you have to inhibit these systems basically to increase the survival. Okay. So sympathetic system blocker, the beta blockers are there. RAS system, you have ACE inhibitors, You have spironolactone, which is aldosterone antagonist. These are the drugs which affect the survival or mortality and not digoxin. Very, very important. Okay, is this clear with everyone? Yes. Next one, bedridden patient now complaining of breathlessness and chest pain. This is classical history of pulmonary embolism. Okay, this is classical history of pulmonary embolism. Why bedridden patient? Because first the patient gets DVT, deep vein thrombosis, because of the immobilization, and then that embolizes to pulmonary artery causing to pulmonary embolism, right? So what is the investigation of choice? CT pulmonary angio. What is the screening test for pulmonary embolism? The screening test is D-dimer. D-dimer is going to be high with pulmonary embolism. If it is high, you want to prove this is pulmonary embolism, then you do CT pulmonary angio. Okay. And then how do you give contrast in CT pulmonary angio, guys? How do you give the contrast? Yes. How do you give contrast in CT pulmonary angio? Very good, correct. So it is given IV. Okay, you are not giving it into any artery, like not the femoral artery or not the or not your pulmonary artery. Okay, this is basically a contrast CT that is done with the IV contrast. Okay, if you do not have CT pulmonary angio in the options, you have non-contrast CT, contrast enhanced CT. Remember that for any vascular pathology, it's a contrast CT that you will do. Shubham, remember that Seldinger's technique is a technique which is used for arterial puncture. Like जब हम femoral artery puncture करते हैं, Seldinger's technique is for that. Okay. Dhwani, if it's a recurrent pulmonary embolism which is occurring, then you use the filter. Okay, Seldinger's technique is for puncturing like the femoral artery. You are not going into the artery. This is vein से हम देते हैं contrast. Going to next one, very, very important, right heart failure versus left heart failure. How do you differentiate the two clinically? Right heart failure, left heart failure. Okay, think logically. In right heart failure, what is happening is the right side of the heart is receiving the blood from the systemic veins, that is superior vena cava, inferior vena cava, right? The right atrium receives blood from there. Left atrium receives blood from the pulmonary veins. So when right side is failing, it's a systemic compartment that's getting affected. When the left heart is failing, it's the pulmonary veins getting affected. So in the left heart failure, you would see pulmonary edema. In the right heart failure, you would see pedal edema. ठीक है, सिस्टमिक वेन से फिर लेग्स में बेसिकली इडिमा होगा, पीडल इडिमा होगा, हेपाटोमेगाली होगा, राइट, देयर इज गोइंग टू बी रेज्ड जेवीपी. All this you would see in right heart failure. Pulmonary edema, and that is what is leading to, you know, the lung में auscultation में फिर आपको rals मिलेंगे. That is going to be heard in left heart failure. Please understand this concept. So pulmonary edema is left heart failure, pedal edema, hepatomegaly, raised JVP is right heart failure. So a patient who is a smoker and smoker now developing COPD, in this patient, what heart failure will you see? Right heart failure or left heart failure? Right, so COPD, pulmonary hypertension, okay, फिर वहाँ पे क्या होगा? Right heart failure होगा. This is called as cor pulmonale. राइट, पल्मोनरी कॉज के वजह से कोरोनरी हार्ट अफेक्ट हो रहा है. सो कॉर पल्मोनल इज राइट हार्ट फेलियर यू आर सीइंग हियर. ओके, क्लियर विथ एवरीवन? Very good. Pink frothy sputum, that all will be seen with the pulmonary edema, that's left heart failure. Okay, right. Going to next one, absent P waves in ECG will be seen in what condition? Two conditions. One is atrial fibrillation and second is PSVT. Atrial fibrillation versus PSVT, both of them might have absent P waves. The difference is here in atrial fibrillation, it's an irregular rhythm. Here you are going to have regular rhythm. Okay, regular rhythm with what kind of QRS? Narrow or broad? Remember, supraventricular tachycardias have narrow QRS. Ventricular tachycardias have broad QRS. Okay, that's how you differentiate. Going to next one, delta wave. Where do you see delta wave? WPW syndrome, where you see the QRS, the Q is going like this, up sloping, not like a straight line. That is where you see delta wave. In WPW syndrome, how is the PR and how is the QRS? How is the PR interval in WPW? PR interval tells you the conduction across the AV node, right? यहाँ पे basically क्या होता है कि there's a accessory pathway which is faster conducting, so the PR interval is short. The QRS is broad because it's an abnormal pathway. Any abnormal pathway leads to broad QRS. Okay, here the short PR, broad QRS, delta wave is what you see in WPW syndrome. Okay, where do you see Osborne wave? Osborne, remember O is seen in hypo. It is seen in hypothermia. Okay, Osborne wave is seen in hypothermia. What is the drug of choice in PSVT? The drug of choice in PSVT, never to be forgotten, is adenosine. Okay, it's adenosine. But what is the first management that you do? The first management that you do depends on whether the patient is stable or unstable. Blood pressure 90/60 से कम है कि ज़्यादा है. Okay, so if the patient is stable, that means you have time, you can experiment and you can do the Valsalvas, basically carotid कर सकते हो, Valsalvas कर सकते हो for the vagal stimulation. Okay, carotid massage can be done. If the patient is unstable, you cannot waste time. So directly we will have to do cardioversion here, right? Directly we'll have to do cardioversion here. Okay? So remember that it is, if the patient is stable, then you will do carotid massage. If the patient is unstable, you will directly go for cardioversion. Okay? Coming to next one, where do you see Beck's triad? Beck's triad is seen in cardiac tamponade. Okay, Beck's triad is seen in cardiac tamponade. What is the triad? Remember it as veins, heart and artery. Okay, that is how the arrangement is. Veins go into the heart, heart में से आती है arteries. So veins वाला JVP, there is high JVP. Heart में क्या हो रहा है? Because there is fluid surrounding the heart, there is muffled heart sounds. Okay, the heart sounds are muffled. Arteries में there is going to be blood pressure which is low, hypotension. This is what is the Beck's triad in cardiac tamponade. Okay, and what do you see in ECG in cardiac tamponade? Because the heart is in fluid, sometimes the heart is coming close to the chest wall, going away from the chest wall. So the amplitude of the QRS is changing, right? So you would see electrical alternance. Okay, electrical alternance, the amplitude is changing. Okay, electrical alternance. And versus where do you see pulsus alternans, guys? Where do you see pulsus alternans? That is seen with heart failure, left ventricular failure. Okay, pulsus alternans, that is seen with left ventricular failure. Okay? How do you differentiate cardiac tamponade from pneumothorax? See, both of them can cause hypotension because of obstructing the heart, right? They are causing obstructive shock. So both of them can cause hypotension. The difference is going to be in pneumothorax, it is breath sounds which are absent. Okay, the breath sounds are absent here, while in tamponade, it is heart sounds which are affected. The breath sounds are normal. Okay, so remember that is the difference in between the two. Okay, give me a quick thumbs up if everybody is with me and you know everything is clear so far, whatever we have discussed so far. Yes. Thank you so much for reminding this. Correct, Siddharth. Remember that in tamponade, what happens in tamponade and JVP is absent Y descent. Remember, there is absent Y descent in tamponade. Okay, absent Y descent in tamponade. Okay. Going to next one, respiratory transudative versus exudative pleural effusion. What is the name of the criteria which helps you to differentiate this? The name of the criteria is the Light's criteria. Okay, if it is exudative pleural effusion, there is increased proteins, increased LDH levels that you see in exudative. Okay. Transudative pleural effusion, remember, are the causes where you have heart, liver, kidney failing. Any cause of heart, liver, kidney failure is a transudative cause, right? So cirrhosis, heart failure, nephrotic syndrome, these are transudative. Versus, where do you see exudative pleural effusion? Where do you see exudative? Any infective cause, inflammatory cause, malignancy. Okay, this is where you see basically exudative. Okay, correct. So remember that rheumatoid arthritis, inflammatory, this is going to be what pleural effusion? Exudative pleural effusion. Infection, inflammation, malignancy is going to be exudative. Heart, liver, kidney failure is transudative. Okay. So this is going to be exudative pleural effusion in rheumatoid arthritis. Rheumatoid arthritis basically is what joint is never affected in rheumatoid arthritis? It never affects DIP. DIP is never affected. The joints which are affected are generally bilateral symmetrical joints which are affected here. Okay, bilateral symmetrical joints which are affected here. Proximal joints are affected, right? You have RA factor positive, a specific antibody is NTCCP. Okay, NTCCP is more specific for rheumatoid arthritis. Yes. Where do you have pneumonia with hyponatremia and diarrhea? Very, very classical history that's given. Pneumonia है और साथ में hyponatremia है और diarrhea है. What is the causative organism here? The causative organism here is Legionella. Okay, remember Legio is GI, it affects the GIT, causes diarrhea. NELLA is Na low. Okay, sodium is low and that is what leads to confusion. Right? So the patient can have diarrhea with confusion because hyponatremia leading to confusion. The other name, the Pontiac fever is also caused by Legionella. The culture medium that you use for Legionella is, remember the mnemonic for culture media for Sureshot, that is BC ले. एक और जोक सुनाया नोटबंदी पे तो BC ले, that is BCYE, buffered charcoal yeast extract. Buffered charcoal yeast extract, that is what is used for Legionella. The drug of choice is macrolides, that is azithromycin. Okay, the drug of choice is azithromycin for Legionella also. Right, classical history in Legionella is going to be, AC में से आता है ये. तो वहां से बेसिकली दिस कम्स कि कोई ट्रिप पे गया, क्रूज पे गया, दैट हिस्ट्री कम्स और वो AC वाला. सो दैट इज AC से एक्सपोजर होता है. नेक्स्ट वन, recurrent pneumonia, steatorrhea, meconium ileus in a child. What is the diagnosis here? This is cystic fibrosis. Cystic fibrosis, because in cystic fibrosis, what channel is affected here? It affects what channel? C for C. Remember, it is chloride channel which is affected, right? The secretions are thick secretions, right? And what is the gene here? The gene affected is CFTR gene, which is present on chromosome 7. The inheritance is autosomal recessive. Remember, the mutation is delta F508. F for what amino acid? F for phenylalanine. Delta F508 mutation, chromosome 7, autosomal recessive. What test do you do here? The sweat chloride test. What happens to sweat chloride? The sweat chloride increases. Okay, the sweat chloride increases. Okay, so there is recurrent pneumonia, steatorrhea, meconium ileus. Because there is steatorrhea, there will be deficiency of fat soluble vitamins, right? So A, D, E, K, that fat soluble vitamins will be decreased. Okay, correct. Going to the next one, neurology mein, what is this condition where you have ascending areflexic motor paralysis? Ascending hai, right? नीचे से starting from the lower limbs, the reflexes are depressed, right? So this is basically Guillain-Barré syndrome, GBS, which is associated with what infection? Campylobacter jejuni. Okay, associated with Campylobacter. Campylobacter का जो होता है poisoning, food poisoning भी कर सकता है by eating what? By eating what? Campylobacter, remember poultry. Okay, remember poultry. And for Campylobacter in microbiology, you should always remember कल्चर मीडियम में क्या होता है at what temperature. Remember Campylobacter in a camp में hot summer camp, the temperature is very high, 42 degrees centigrade, micro aerophilic environment. At the camp, high altitude वाले camp पे the air is less, right? So remember micro aerophilic, 42 degrees centigrade is Campylobacter. Very, very important. Very good. Remember CD, Campylobacter has darting cholera is darting, right? So remember the CD was a cholera and darting. Correct. Going to next one, this is ascending. If the question is versus descending वाला किस में होता है? ये ऊपर से start होता है. It affects the eye muscles, maybe the neck muscles. That is what is affected. Descending is botulism. Botulism is descending. क्या खाने से botulism होता है? Remember botulism is bottled food. बॉटल्ड फूड, कैंड फूड खाने से बॉटुलिज्म होता है. इन्फेंट बॉटुलिज्म होता है किससे? हनी कॉजेस इन्फेंट बॉटुलिज्म. ओके, यस. नेक्स्ट वन, टोसस, फटीग, मोर इन द इवनिंग. दिस इज क्लासिकल ऑफ myasthenia gravis. Myasthenia gravis, the more the patient exerts, right, the more is the fatigue. Jitna muscles zyada use karenge, the fatigue will go on increasing, so it becomes more in the evening. Opposite to this is incremental, on repeated stimulation of the nerve, there is incremental response that is seen with Lambert-Eaton. Lambert-Eaton is opposite. Myasthenia gravis, on exertion, basically the fatigue increases. In myasthenia gravis, there is antibodies to presynaptic, postsynaptic. Remember Lambert and myasthenia. L comes first, presynaptic. M comes after, postsynaptic. There is antibody to postsynaptic acetylcholine receptor antibody. Right? It's a type 2 hypersensitivity, now classified as type 5 hypersensitivity. Okay? Can you tell me what HLA is associated with myasthenia gravis? HLA B8. Remember, myasthenia gravis is like Mahatma Gandhi MG. Mahatma Gandhi ka chashma, the figure of 8 appearance. Remember, it is HLA B8. Okay, HLA B8, myasthenia gravis. What is the drug which is used for diagnosis and what is the drug which is used for treatment? Diagnosis. Who does the diagnosis? Doctor. So remember edrophonium, which has doctor in it, DR, edrophonium tensilon test. Treatment helps you get rid of the condition, right? So remember it is pyridostigmine, which helps you get rid of it. Pyrid helps you get rid of myasthenia. So pyridostigmine is treatment, edrophonium is diagnosis. Very, very frequently asked question in your exam. Okay, correct. Multiple episodes of neurologic deficit plus optic neuritis is seen in multiple sclerosis, MS. Okay, multiple sclerosis, where you use what interferon in the treatment of multiple sclerosis? Interferon alpha, beta, gamma. We use interferon beta. Okay, pulse steroid is given in the acute relapse of multiple sclerosis. You can use natalizumab, right, which is also used there. Okay. Recurring headache with positional variations, positional and diurnal variations in a obese female. Classical history एक obese female है, on OC pills है, and now having headache, right? What is this basically pointing to? What is the cause of headache here? It is, what is it? Idiopathic, intracranial, hypertension. That's basically pseudo tumor cerebri. Okay, pseudo tumor cerebri is obese female में होता है, young adult obese female में, and because of the hypertension, the raised ICT which is happening here, remember it will also have papillae edema which is present. The raised ICT will lead to papillae edema also. So that's the classical history here. And tell me that pseudo tumor cerebri is seen with toxicity of which vitamin? Which vitamin toxicity there is pseudotumor cerebri? Vitamin A. Remember, vitamin A toxicity is pseudotumor cerebri. Correct. Look at the image here, which is LMN palsy and which is UMN palsy of the facial nerve. Look at the forehead to identify that. Okay, look at the forehead to identify that. Both side wrinkles are present here. यहाँ पे it is absent. So basically यहाँ both side upper is normal, upper में it is not involved, right? So remember this is going to be UMN palsy. Remember in UMN, you can remember it as UMN, upper may not involved. Okay, upper may it is not involved in UMN. The upper is spared. Right? Is it right-sided UMN palsy or left-sided UMN palsy? Is this right or left? Which facial is basically gone here? कौन से side का गया होगा so that the patient is having this? This is right, this is not the right, this is left-sided because you are seeing here this is where the patient is not, these muscles are not functioning. Okay, these muscles are not functioning. Is this clear with everyone? This is left-sided. Opposite side jata hai. Opposite side is what goes in the UMN palsy. Okay, is this clear with everyone? The drooping is seen here. Correct. This is left-sided UMN palsy. And what do you see here? Jahan pe wrinkling nahi hai, wo side ka hai. This is right-sided LMN palsy, that is Bell's palsy. So how did we remember that is UCL lie. Okay, UCL, jo UCL league hai, lie. Upper में C for contralateral lower is involved. Lower motor neuron palsy में ipsilateral entire half is gone. Okay, upper नीचे दोनों साइड का जाएगा. जैसे यहाँ राइट साइड में गया है तो राइट साइड का है. यहाँ पे if there is right sided upper motor neuron, the left side is what will be affected. Okay. Done. Going to next one, CSF meningitis. Very, very important. Viral is the one where glucose is going to be normal. Viruses do not eat glucose. That's how you remember the CSF glucose is normal. Otherwise, the CSF glucose decreases in meningitis. In TB, there is going to be increase in lymphocytes, right? And you have cobweb coagulum which is formed. Plus, you have a lot of basal exudates, right, which are present. And if you do MR spectroscopy in tuberculoma, CNS tuberculoma, what peak do you see in CNS tuberculoma, guys? What peak do you see in MR spectroscopy? Very, very important. Remember, it is the lipid peak is seen. TB has lipid peak. Mycolipid, mycobacterium has mycolipid. Okay, mycobacterium has mycolipid. Somtubra, bacterial versus fungal. Remember, bacterial will have neutrophils increased, fungal will have lymphocytes increased. And fungal generally you see with immunocompromised status. Okay, immunocompromised status. So, bacterial is the one, you know that with bacterial infections, it is the neutrophils which are increased. In fungal, it is lymphocytes which are increased. Plus, fungal is going to be like cryptococcal. This is going to be like HIV positive patient, immunocompromised patient. What is the drug of choice for cryptococcal meningitis? It is amphotericin B plus flucytosine. Okay, not fluconazole, flucytosine. Then in the maintenance phase, then you give fluconazole in the maintenance phase. Okay, otherwise first it is amphotericin B and flucytosine. Okay. Other peaks in MR spectroscopy, remember if it's a brain tumor, there is choline peak. The concept behind that being tumor में cell turnover ज़्यादा होता है. So the choline in the cell membrane that increases. Okay, so there's choline peak in the brain tumor is what you see. Lipid peak is what you see with TB. Normal brain, normal parenchyma should have NAA peak. N for N. Normal is NAA. Okay? Right. Thank you so much, Dr. Pragati. This is again a previously asked question. Paracentral lobule में अगर lesion है तो क्या क्या affect होगा? Remember, paracentral lobule is PL, paracentral lobule. It affects the perineum and the legs. Okay, the perineum and the legs. This is supplied by ACA. Okay, so when there's ACA infarct as well, you would see urinary incontinence and lower limbs are affected more as compared to upper limbs. Okay. All right, look at this image and tell me what are you seeing in this image here. This white that you are seeing here, all this is the blood. Okay, this is the blood which is in place of CSF. So basically you are saying कि जहाँ पे CSF होना चाहिए थे dark, it is being replaced by the blood. CSF is present in subarachnoid space. So this is going to be subarachnoid hemorrhage. Okay, this is going to be subarachnoid hemorrhage where the patient comes with worst headache of life, right? Thunderclap headache is what is the classical history which is given here. And what is a common cause of subarachnoid hemorrhage? It is aneurysm. Berry aneurysm rupture is what leads to subarachnoid hemorrhage. Berry aneurysm which is present where? In the circle of Willis. Okay, so that aneurysm rupture leads to subarachnoid hemorrhage. What calcium channel blocker do you use in subarachnoid hemorrhage? Amlodipine, nimodipine, diltiazem, verapamil, nicardipine. What is used? Very good. That is nimodipine. Very, very important. The calcium channel blocker which is used in subarachnoid hemorrhage is nimodipine. Okay, it is nimodipine. Is this clear with everyone? Right. If it is the aneurysm involving the PCOM artery aneurysm is what leads to third nerve palsy. Okay, PCOM aneurysm leads to third nerve palsy. PCOM or PCA or even SCA aneurysm. Right? Done with this, going to the next one, endocrinology. What is the drug used in these drugs which are used in treatment of which condition? Lanreotide, octreotide. Okay, lanreotide, octreotide, where are they used? Most common cause is trauma, correct. Where do you use lanreotide in the treatment of? Yes? Which endocrine condition? Absolutely right. It is used in acromegaly. Okay, it is used in acromegaly, you know, like octreotide, lanreotide. Where are they acting? On the somatostatin, right? So, somatostatin, static, making the soma growth static. It is used in acromegaly. Similarly, pegvisomant, som antagonist body को जो grow कर रहा है, this is also used in acromegaly. Pegvisomant, this is used here. Okay. Terlipressin, where do you use terlipressin? Remember, you have, this is sounding like vasopressin. So this is like a vasopressin analog, but which acts on the V1 receptors, which is present on the blood vessel, causing the vasoconstriction. This is used in esophageal varices. Okay, esophageal varices. And versus if it is central diabetes insipidus, we use desmopressin. Right, desmopressin is used there. Where else do you use desmopressin? Where else do you use desmopressin? Desmopressin helps in releasing the von Willebrand factor. So it is also used in von Willebrand disease. Okay, also used in von Willebrand disease. Correct. If it is nephrogenic diabetes insipidus, then what do we use? Nephrogenic diabetes insipidus. Then we use thiazides. Okay, then we use thiazides for nephrogenic diabetes insipidus. Okay, clear with everyone? All right. Going to next one, classical history of sudden onset headache, palpitation, sweating, urinary metanephrines are increased. This is classical history of pheochromocytoma. Okay, pheochromocytoma, which is a tumor of, where does pheochromocytoma arise? Adrenal cortex or adrenal medulla? It is the tumor of adrenal medulla, right, where you have the chromaffin cells, the catecholamine being synthesized. So there is increased catecholamine sympathetic stimulation, hypertension, sweating, palpitations that will occur. Increased urinary metanephrines, VMA levels is what we see there. Okay, and What rule do you have in pheochromocytoma? Rule of 2, rule of 5, rule of 7, rule of 10. Remember, it is rule of 10. 10% bilateral, malignant, children, syndromic, right? That is what you have, rule of 10. And pheochromocytoma you see in what men syndrome? Men 1, men 2. What men syndrome? Remember, this is component of men 2, right? Where you have neural crest cell wale tumors, where you have medullary thyroid cancer. Correct? Remember, there's medullary thyroid cancer, pheochromocytoma in men 2. Okay, clear with everyone? Absolutely right. SS, remember that if it's an adrenal pheochromocytoma, in that case is adrenaline, that is epinephrine increases. अगर extra adrenal वाले हैं तो वहां पे norepinephrine भी बढ़ता है. Yes, correct. And what is a nuclear scan that you use for pheochromocytoma? MIB scan, MIBG scan, DTPA scan. What scan do we use for pheochromocytoma? It is MIBG scan. Okay, MIBG scan is what is done for pheochromocytoma. Correct? Going to next one, classical history of abdominal cramps, bone pain, nephrocalcinosis, abnormal behavior. Right, there is stones, bones, groans, moans. This is classical history of what endocrine disorder? Hyperparathyroidism. It leads to hypercalcemia, nephrocalcinosis. Okay, and in hyperparathyroidism, never forget we do SISTA-MIB scan. SISTA-MIB scan is what is done for hyperparathyroidism. Okay, SISTA-MIB or just the MIB scan may be mentioned in the question. Okay, SISTA-MIB scan. Now, technetium-99, Shubham, is the isotope. To that you bind like MIBG. Okay, so technetium-99, MIBG scan. That is what you should remember. Coming to pancreatic neuroendocrine tumors, Whipple's Fried is seen in insulinoma. Right, low glucose level, symptoms of low glucose, you give the glucose, the patient becomes normal. So basically that will have hypoglycemia ke features. Whipple's triad is seen in insulinoma. Anemia, necrolytic migratory erythema. Remember, this is migratory erythema, that is erythema going here and there. Going is glucagonoma. Glucagonoma, gone, going wala erythema. Glucagonoma is what shows necrolytic migratory erythema. WDHA, watery diarrhea, hypokalemia, achlorhydria. This is seen with what tumor? VIPoma. Okay, VIPoma is what shows watery diarrhea, hypokalemia and achlorhydria. Where do you have diarrhea with flushing? When you see history of diarrhea with flushing, what tumor are you thinking of? Carcinoid. Okay, diarrhea with flushing is seen with carcinoid. Carcinoid affects what valves of the heart? Right-sided valves of the heart, like it shows tricuspid regurgitation. Okay, that right-sided valves are affected commonly with carcinoid. In carcinoid, basically what happens, there is increased serotonin. Right, and the metabolism of serotonin that gives 5-HIAA. Classical history given increased urinary 5-HIAA is what is there in carcinoid. Carcinoid will lead to what vitamin deficiency? Carcinoid will lead to vitamin B3 deficiency. Okay, it will lead to vitamin B3 deficiency because both serotonin and B3 are being synthesized from tryptophan. Okay, so all the tryptophan is going to serotonin, so there's going to be B3 deficiency. Absolutely right. In DKA, what is the drug of choice? Diabetic ketoacidosis. When do the ketones increase in the body? Right, when there is low insulin. So insulin deficiency वाला है तो treatment में आप क्या दोगे? Regular insulin, which is given IV here, plus you have the fluids which are given. Right, that is what you have. Diabetic ketoacidosis is a metabolic acidosis, which is HAGMA, okay, which is high anion gap metabolic acidosis. Dhwani, carcinoid will classically have history of diarrhea with flushing. Hartnup will not have this history of diarrhea with flushing. Hartnup is a condition where the absorption of these amino acids, including tryptophan, is affected, and that is why you see that B3 deficiency. It will not have raised serotonin. Okay. Yes, beta hydroxybutyrate, because that is what is the ketones, right? So that will be increased. Okay. Going to next one, rheumatology. What are you seeing here? The lilac rash, the heliotrope rash, the Gottron's papules. All these are findings seen in dermatomyositis. Heliotrope, that is lilac rash, Gottron's papules, plus you have the shawl sign. This is seen in dermatomyositis, where you have what antibodies? Anti-Jo antibodies. Okay, anti-Jo antibodies. Remember, dermatomyositis can be a tumor in ovarian cancer, right? So remember, this is basically paraneoplastic in ovarian cancer. So you will have CA125 levels that you need to check here. Dermatomyositis, it affects the proximal muscles. Okay, there's going to be weakness of proximal muscles with the skin manifestations. Next one, very, very important, where you see this dagger sign, fusion of the sacroiliac joints. The entire spine is getting fused. Remember, fused spine. Fused matlab ankylosing, and the spine means spondylitis. So it is ankylosing spondylitis. Ankylosing matlab fusing, spine, inflammation. It's an inflammatory arthritis. So remember, there can be morning stiffness history that can be present here. Inflammatory arthritis has morning stiffness. It can also have history of red eye, because the extra-articular manifestation, there is anterior uveitis. The patient can have red eye with back pain. Where does it start? It starts in the SI joint, low backache, right? That is where it starts. What do you give in the management? NSAIDs, right? For symptomatic improvement. Ankylosing spondylitis. The sign that you see here is the dagger sign. Bamboo spine, dagger sign is what you see here. Bamboo spine is the fused spine. Okay. Look at this one, when you have the great toe affected. Great toe. GTO is GOUT, that is gout. Pain in the great toe. First MTP joint is what is affected. That is gout. And this is generally the history that will be given is patient went to the party last night, had alcohol, and now has pain. Remember, it is precipitated by alcohol. Okay, it is precipitated by alcohol intake. That's important. And what are the drugs used in acute gout? Do you use allopurinol in acute gout? No. Remember, allopurinol is not used in management of acute gout. You use NCC. NSAIDs, corticosteroids, and colchicine. Okay, these are the drugs used in the acute management. Even in NSAIDs, you do not use aspirin. Okay, allopurinol is not used in acute attack of gout. It is used to prevent the acute attack, right? Prophylactic wala to prevent the acute attack. Great. Going to next one, first CMC joint which is affected, Bouchard's nodes, Haberden's nodes. These are classical of osteoarthritis, which is degenerative arthritis. Okay, osteoarthritis, degenerative arthritis. The first CMC, it can affect the DIP also, and you have the Bouchard's and Haber nodes. Remember, Bouchard's is proximal, PIP, Haberden's is DIP. B comes first, H comes later. PIP and DIP पे होता है ये Bouchard's and Haberden's nodes. Okay? Right. Going to next one, hepatobiliary. What is Child-Pugh score used for? The child score. Remember, child. Child is used for cirrhosis, that is cirrhosis. का severity देखने के लिए compensated है, decompensated है. And what are the components? The mnemonic for that is every child has एक बाप. Right? Remember, 5 components: एक बाप, encephalopathy, bilirubin, ascites, albumin, and PT-INR. Do you have AST, ALT levels here? No. Okay. Remember, it is child score is for cirrhosis. Correct. And what is the score that you use for liver transplant priority? Which patient should get the priority for liver transplant? What score do you use for that? MELD score. Okay. Model for end-stage liver disease, MELD score, originally which had what components? In the end stage, who comes in the investigation? CBI. So, creatinine, bilirubin, INR. Okay, CBI. The updated one is adding FAN. Female gender, albumin and sodium are also added in the updated one, the recent one. Okay. Pruritus, grey colored stools. Whenever you get this history, grey colored stools hai, pruritus hai, you are thinking of obstructive jaundice. In a patient who had diarrhea with mucus already, so that's a patient of ulcerative colitis with obstructive jaundice. Always remember the association. This is primary sclerosing cholangitis associated with ulcerative colitis, primary sclerosing cholangitis. Sclerosing means there's going to be a lot of fibrosis. So it shows this onion peel fibrosis. That is what you see here, onion peel fibrosis, right? On MRCP, it shows beaded appearance on MRCP. Okay, never forget this, important. Next one that you have hereditary hyperbilirubinemia, which are conjugated, which are unconjugated. Remember, doctors conjugated, remaining ones are unconjugated, where you have Gilbert and Crigler-Najjar. Gilbert and Crigler-Najjar, these are unconjugated, doctor is conjugated. Out of this, which is the benign? Remember, BE. Gilbert is the one which is the most benign. Almost normal patient except for periods of stress like infection vagera, where the jaundice precipitates. Okay. In Crigler-Najjar, you have Crigler-Najjar 1 and 2. 1 is the one which is the most severe. There is absent conjugating enzyme. The UGT1A1 is completely absent. Right. So, that is one which is most severe, and that is the one which has high kernicterus. Maximum kernicterus is seen with that. Okay. In conjugated, D for D, remember Dubin-Johnson is the one which shows dark liver. Pigmented liver, dark liver is what you would see with Dubin-Johnson. So, doctor conjugated, Gilbert and Crigler-Najjar is unconjugated. That is what you should remember here. Very, very important, right? Of course, we have discussed all of this in detail in our short videos in the Radsynapse app as well, right? These are the flashcards that have already been covered in the pathology short videos, guys, right? In the Radsynapse app again. So, this is for your last minute revision. I've added in the PDF. I've discussed all of this with the tricks again in the short. Okay, so these are the flashcards. Do go through them. All these points, majority have been discussed. Okay. So, that was about the today's session for the FMGE final punch short first session. Right, I hope this has been like a good revision of the most important points, right? Make sure you are very, very thorough with this. We will have 3 more sessions, like I said, tomorrow, day after, and on 10th as well. So tomorrow again, we will meet at 12 noon, guys, for another session where we will try to cover more topics, more subjects. I'll share the PDF on the Telegram group, right? So you can get the PDF from there. The annotated PDF will be shared there. Oh yes, so we were supposed to discuss about what to revise in the last days. See, in these last days, most important, you should quickly go through all the PYQs. Do not solve them, right? Don't try to solve them and think actively on them. Just try to revise, like, this is like a one-liner flashcard that you are trying to revise. Ki question answer ek baar sirf just go through that quickly. Plus, each one of you will have your own volatile topics list from every subject. Just focus on that. Do not try to revise everything of all the 19 subjects. That's practically impossible, right? So do try to revise what are your volatile topics and are frequently asked. I'm pretty sure you have it by now. And all the PYQs, you should quickly go through them. Not reading the explanation in detail, just a question answer is what you can do. That is something that you can do, when you are bored and you don't feel like studying. So just go through the question answers quickly. That is what basically you should be doing. Thank you so much, everyone. Sagar, we need to look into the prospectus honestly, right? And before your exam, you should definitely know this. Even I'll try to look into it and give you an update tomorrow. Okay? And how to concentrate in the last days, the more you detach yourself from the results, the more you'll be able to concentrate. If you keep worrying about paper kaisa hoga, difficult hoga, easy hoga, what if it comes from the areas that I've not read, what if I don't get good, all of that, if you keep thinking, right, then you will not be able to concentrate. Okay, so do definitely put a lot of things into your short-term memory for the exam, because that really helps. Tomorrow 12 noon again. Okay, Lopa, there are a lot of tricks in genetics that we have discussed in the Radsynapse app, right? So please watch the videos from there. We have discussed the various chromosome numbers, the inheritance patterns, the various syndromes like Downs, Patau's, Edwards, and all of that. Plus in biochemistry also, molecular biology has been discussed there, right? It's practically impossible to discuss everything here again in the last 2 days. So if you want, you can watch it from the Radsynapse app. Okay. Should you go through AIIMS 2024 and NEET PG? If you have not gone yet, then you can skip the AIIMS one, but NEET PG you can definitely go through it quickly. ठीक है, AIIMS आप skip कर सकते हो if you have not done it before. If you have done it before, then revise, yes. But if not, then skip. Okay, but at least NEET PG तो आप देख लेना. That is something that you should do. Okay, and make sure that you have your things what I have to read in this last days. You are not wasting your time in deciding कि आज क्या पढूं और कल क्या पढूं, right? Have your to-do list ready for these last 3 to 4 days. Do not waste your time in just thinking over what to do. Yes, this video will be there even after the live gets over. Okay, and guys, if there are any suggestions for any topics that you want to be covered for this last minute revision, like anatomy is being asked for, I'll try to cover important topics there. Apart from that, if there are any other suggestions, please do let me know, tag me on the Telegram group, so that I know that these are the suggestions that you have. Okay. All right. Thank you so much, everyone. And I'll see you again tomorrow at 12 noon YouTube live session. Till then, goodbye. Take care. Keep studying, keep revising, keep Radsynapsing, and keep winning. Thank you.